Hi and welcome. I'm Nelifa. This is Dear World Live.
How do we construct our economy in a way that is climate friendly?
It's 2 times as difficult for disabled people dealing with COVID than it is for their non-disabled peers.
How do we actually ensure women's inclusion? How do we ensure women's safety?
Hello, hi and welcome. It's me, Nelifa. This is a very special edition of Dear World Live from Doha Debates as part of the World Innovation Summit for Health. In this season of Dear World Live, we're focusing on race and racism across the world. Each week, we focus on a different aspect of this very important conversation. Today, we're talking about how racial inequality impacts the difference in healthcare standards that people across the world receive. My wonderful guests today are Dr. Motsadiso Moyeti, Doreen Maracha, and Dr. Cameron Abbasi, who will be joining me soon. But first, I want to start this discussion by framing it in the context of the coronavirus pandemic, which has exposed existing racial healthcare inequalities. In the United States, Latino and African American people are 3 times as likely to become infected with COVID-19 as their white neighbors. And they're almost twice as likely to die from the disease. In the UK, the story is reflected where the death rate of people from Black, Asian, and minority ethnic groups is 1.5 to 2 times higher than those of white people. These facts are from places where there is an abundance of data to help us illustrate the problem. But healthcare racial inequalities are a truly worldwide issue. And it's not the first time we face a global health crisis. In the 1980s, HIV was a global epidemic that affected millions of people, and not everyone had access to the same quality of treatment. As we'll hear during today's show, this is one area of treatment we have got a lot better at. But for now, it's clear that globally, minority communities are likely to be most at risk from COVID. In fact, in Australia, some Indigenous communities have taken strict self-protection measures by preemptively limiting contact with the general population. We'll talk more about this, but first we put the call out to our friends at the Shared Studio Network and asked if you've experienced healthcare inequalities in your life. We got one particularly powerful story and answer from Lewis Lee, a restorative justice advocate and outreach coordinator for the Milwaukee Fatherhood Initiative in the US, which provides skilled training for formerly incarcerated fathers returning to their communities. Here's his response when asked if he has experienced healthcare inequality.
When I was 18 years old, I was a shooting victim. I was shot 5 times, and the mother of my children called the ambulance. The ambulance came, rushed me to the hospital. I thought when I got to the hospital that I would get like A1 service because I was a shooting victim. I thought they would like really take my examination and my care real serious, but unfortunately they didn't. I think a lot of that had to do with the color of my skin, the actual neighborhood I was from, and just the actual income that I had. I believe a lot of times African American people, especially males, when we get rushed to hospital, we don't get the quality service that we deserve. I was kind of given a rush job and rushed out of the hospital straight into the arms of MPD and straight to the county jail infirmary, where it took me 4 months to heal and get back to my normal self. So I felt that was kind of racist, and I felt that if I had been white, that I would have got better service. Had I came from the suburbs, I would have got way better service. They would have took my case a little more serious.
Very powerful story there from Lewis Lee, and something that I want to reflect on. But this is Dear World Live, and it's nothing without your involvement. For our regular viewers, you know the score. We depend on your comments, on your engagement with the show. Are we asking the right questions? Do you have any comments? Is there anything that you want to see in the show that we haven't talked about yet? For those of you who are watching at the World Innovation Summit for Health, Get involved. Take out your phones and tell us what you make of the show so far. We are at Doha Debates on Twitter and all the various other social channels. For now, why don't you just tell me where you are watching from and what your name is? I will feature as many of your comments in the show as I can. So, without any further ado, it's time to introduce our wonderful guests. Dr. Matshidiso Moeti is the first woman to be elected as Regional Director for Africa for the World Health Organization. Doreen Muracha is a young woman living with HIV from Kenya and the founder of I Am a Beautiful Story and a campaigner to end the stigma of HIV and AIDS. Dr. Cameron Abasi is a physician and writer and the executive editor of the British Medical Journal and editor of the Journal of the Royal Society of Medicine. And we are grateful to be joined by our wonderful student. Khadija Owusu is a final year medical student here in the United Kingdom and a founding member of the charity Melanin Medics. I am so grateful to have you all on the show. I want to start with my guests, Dr. Moeti and Dr. Abasi. I have a couple of questions for you guys specifically. So COVID-19 has already shown the inequalities in healthcare that people might experience based on their race. My question is, do you think everyone in the world is going to get equal access to the COVID-19 vaccine, two of which are hopefully going to be coming to market before the end of this year? Are people going to get equal access to the vaccine? But also, will that access have anything to do with racial inequalities? Dr. Moeti, let me start with you.
Okay, thank you very much. And first, I'm really thrilled to be part of this panel. And what a great group of panelists. And be back at the Wish, which I attended a couple of years ago in person. So it's a very exciting moment for me. Yes, the emergence of the two vaccine candidates that are promising in phase 3 trials has really encouraged us all. It's true we need to wait for full efficacy and safety data to be available, but we're all gearing up to make sure exactly that there is equitable distribution. And coming from Africa, I have to say our experience in the past has been that when a new technology comes out, African countries are kind of at the back of the queue to get it. And we've seen that sometimes it takes a decade for a new technology to be available in Africa in a scaled up fashion in the health systems. So coming back to this vaccine, this was thought about as the development of the vaccine was happening, and a coalition was established at the global level to guard against inequity in the distribution of the vaccine, the WHO and Gavi, and both low-income, middle-income countries and some upper-income countries who are partners and contributing financially, just to that very aim to have equity. However, we've seen that wealthy countries, mainly Western countries, are entering into advanced purchase agreements with vaccine manufacturers to reserve doses. So from the African perspective, we are very concerned, but are also hoping that we hold to this principle of equity, and that we don't have deals being entered into which countries which will then sweep up the supplies and stop. We're hoping for at least initially 20% of populations to be covered in Africa, starting with the most vulnerable. Now, turning to Western countries, where I think you've said very well that Black people, people of African origin, other minorities are disproportionately affected. We hope very much that when these countries prioritize who's going to get the vaccine first, they will genuinely look at those who are worst affected, and that we do not have one inequality based on geography, income level of countries, and also racial inequality. As far as Africa is concerned, of course, we have the possibility for both. But it's our hope that the COVAX facility, which WHO has put in place as part of a coalition for equity at the global level, will reduce the chances of inequitable access.
Dr. Moeti, thank you so much for that eloquent answer. I can sense the concern in your voice. You're being very diplomatic about it, and I respect and appreciate that. Dr. Abasi, if I might come to you, what does history teach us? Do we think that this new COVID vaccine, the hope that is riding with it, all of our collective wish that it's successful, do you think that will be dispensed equitably?
Okay, welcome. Good to speak to you today. Can I just say, I don't need to be diplomatic here because I don't work for the World Health Organization. I think we have two problems. I mean, first of all, there is the kind of the hope around the vaccine. We all want the vaccine to be effective, to save lives, and to be equally distributed. First of all, we don't really know whether any of these vaccines work as well as we want them to, whether they're going to save lives. We haven't seen the data. So, yeah, there's optimism, but it's a bit unfounded at the moment, shall we say. But let's assume that we do have a vaccine at some point available next year. I'm afraid the lesson from history, from our experience, is that these things are not equitably distributed. And I think my fear is that on this occasion, everything will be much worse because for one simple reason. And the reason is this, that this will be an unprecedented delivery, rollout, vaccination program in the history of humanity. We've never done anything on this scale before. And so if you pitch yourself into that scenario, what you will inevitably find is that whatever disparities exist, discrimination exists, inequalities exist, they will be heightened and exacerbated when we start rolling the vaccine out, which is a very good reason for WHO and others to put together this coalition that we call COVAX for fair distribution of the vaccine. But my concern is that that isn't going to happen. The rich countries are going to prioritize their own political agendas to serve their populations. And unfortunately, we will not get the rollout to poorer countries that we should get. And all that will happen is this will be another example of how inequality is exacerbated.
Do you not find what you're saying right now incredibly egregious, Dr. Abbasi? The fact that you're telling the truth, we both know you're right, and yet there's little that can be done about it.
No, it's not well, no, I do. I mean, it's very disturbing. We cover these issues on a daily basis in the BMJ, and it's scandalous, it's horrific, it's a reality that we face. And these are the things that we need to change through collective will, through leadership, through determination. But unfortunately, what we have is we have certain regimes in the world, shall we say, who aren't, thinking globally, and things may have changed with elections. But we need the world to come together. We need solidarity. We need countries to work together. We need the leading nations in terms of influence to come together and share things equitably.
Absolutely. At this point, I would like to thank all of the guests who are joining us. It seems that we might have lost the connection with Doreen Maracha, but I will try and get that up as soon as possible. And as soon as we have Doreen, she can add such insight into how we can learn from lessons in history. For now, those of you who are watching, welcome to Dear World Live. I'm Nelifa Hidayat. This is a production brought to you by Doha Debates. I would like to spend some time thanking you guys for tuning in from Sudan, Khartoum, Mohdi. Hello to you, Dr. Govinda Clayton, a fan of the show, watching from Zurich. We've got people from Sierra Leone in West Africa, Mohammed Marha, thank you for joining. Nigeria, a Nigerian in Doha. Hello, Jamila, good to see you. And in fact, Kadnan in Mogadishu in Somalia, Mohammed in Qatar, you are all very welcome. Tell me your comments and your questions. Do you think that the COVID-19 virus vaccine will be distributed equitably around the world, and when it comes to racial equality? Okay, I want to move on slightly and bring in our wonderful student, Khadija. Khadija, hello. You are a student of medicine right now. You invented, or you co-created Melanin Medics. First of all, why did you do it? What was the need, and what does it do?
Thank you. First of all, I do want to say thank you for having me on the show. It's honestly a privilege to be amongst these amazing guests. But yes, I co-founded a charity called Melanin Medics, set up by one of my good friends, Alamazay Dada, as well. And Melanin Medics essentially is a non-profit organization, a registered charity that aims to widen aspirations as well as promote diversity in medicine and aids career progression. So we basically thought that, okay, representation in medicine is one of the key issues that exist, especially in the UK. And that's the reason why we set up the charity, in order to combat some of those issues.
So I guess my other point is, as a Black woman yourself, when you've ever had to access healthcare, whether it's in a hospital, whether it's reproductive health or GP surgery, a general practitioner surgery, do you feel it? Do you sense it as a person? I just want to try and get a sense of your experience.
Yeah, no, definitely. So for me personally, it would more so be on the other side, as somebody that is providing the healthcare for patients. Of course, within limited capacity, as I am still a student, but you do often see these inequalities play out. A lot of these biases that are inherent in amongst various healthcare professionals, whether it be related to, we know about the maternal mortality amongst Black women and white women. We also know about Black people being less likely to prescribe adequate pain medication, as well as, with COVID-19 being more likely to die from COVID if you are from a Black and ethnic minority background. So as somebody who's a healthcare provider and seeing these, of course, it is not good to watch.
Thank you. I'm going to come to your question for our wonderful guests, but I think we have Doreen back. Can I just test the wonders of internet magic? Is Doreen here? You have left me on tenterhooks, Doreen. Let me tell you that. It's good to see you, my love. Are you in Kenya right now?
Yes, I'm in Kenya.
Okay, so I'll keep it nice and short just because the connection is tenuous. Doreen, you've been dealing with the public health issue of HIV and AIDS and the epidemic that's run rampant around the world since the 80s. My question to you is very specific. You're based in Kenya and you've lived with HIV since, I believe, 1992. Here's the thing. How did your access in Africa, in Kenya, of HIV treatment compared to those who are trying to access it in the global north, here in maybe London, where I live?
So for us, living with HIV, when I was first diagnosed in 1999, there was no medication. So my parents were just told, take her home and just wait upon the Lord, because there was no hope that I was going to live to this point, like to 2020. So as time went by, medication came, the ARVs came around 2001, 2002, but they were very expensive. So they were not accessible for everybody. So still we were not able to afford them until 2005, when they were made free for everybody. Then I was able to access medication, and that is when I started medication. So for 13 years of my life, I was not on any medication.
We use these very evocative words, just as a layperson. I mean, I now know what the difference between a pandemic and an epidemic is, but we use these words and we think, oh gosh, this sounds terrible. But for 13 years, Doreen, you didn't have access to medication that you needed, that the world had. What does it make you feel and think when you think about the potential for these two new COVID-19 vaccines? Do you think they will be dispensed correctly around the world? Do you think the continent of Africa will have access in the same way that Europe does?
I have my reservations. I feel like Africa might be left behind, just the same way it was left behind before, during the HIV epidemic, because we have seen all through, even to a point that when medication came, when the first batch of ARVs we had were very harsh to our bodies, and we were not really given a choice, because when we went to hospital to complain, I remember one time the doctor told me, it's either you take the medication or you don't take them and die. So you have to just live with the side effects. So with the new COVID-19 the two vaccines, I kind of feel like Africa might again be left behind, or we might be brought something that might not work on us or might not work well on us. And then we will be forced with the choice of, you just have to deal with it. You just have to live with it. It's either you live with it or you just don't take it and you die. So those are usually not very, very appropriate choices to make, but then because you have to choose life, so you choose the only available option that you have. Because when I went to hospital and told my doctor, I'm experiencing all these side effects, she told me you just have to take them. You don't have a choice. It's either that or death, and that is not usually a very easy choice.
Doreen, incredibly powerful report there. Just what you're saying is very hard to hear, but I want to bring in someone who can make a difference. Regional Director for Africa in the past with the World Health Organization, Dr. Mayeti, when you hear Doreen, a citizen of Kenya, of the African continent, what responsibility do you feel to make sure that the outcome or the distribution of these COVID-19 vaccines are equitable, so Doreen doesn't feel like this?
Yeah. Thanks. Actually, Doreen, just to let you know, I've spent about a third of my life working on HIV and exactly on access to antiretroviral drugs. In fact, I was the leader of that work. There was an initiative by WHO called 3x5. So I know exactly what you're talking about, how painful it was. And I worked on HIV in my country, Botswana, and that at the pre-treatment days, it was extremely painful. And so I think that we need action on several fronts. You know, you showed there was a clip in the film of some men, I think that was in Manhattan, demonstrating and marching. It looked like a US city. So in addition to this coalition of like-minded countries that I was talking about, which includes some European Union countries, some Asian countries, Latin American countries, as well as virtually all the African countries in hope, I think so we need that kind of initiative to push. So my staff and I with partners are doing all our best to persuade the African countries to go for it, go looking for the money. Let's have a pooled approach so that we constitute a market that's going to be competing. I mean, understanding very much all the bad history and experiences, including around HIV. And then we're working with the countries to get ready now. So in fact, we are doing an assessment of their readiness and preparing to roll out the vaccine in terms of all the logistics, the technical work that needs to be done. I do think one of the best experiences from the HIV era was the solidarity among people.
Yeah.
Indeed. And at the moment, you know, COVID-19 has become very political, as we know, much more than HIV did. You know, governments are falling or rising based on what their population think, how well their populations think they've done on HIV. I remember groups of American gay men with HIV hounding a certain head of state everywhere he tried to speak, because they perceived that rich countries didn't care. They weren't doing anything to the pharmaceutical sector to deal with fair pricing. That head of state could hardly speak at a conference. Everywhere he walked in, there were people, no, you don't get the space until you do something about this. So I think if we could work at different levels, these kind of coalitions and partnerships, and get people to be the force to overcome the reticence of their governments, the kind of nationalism that we do see politically on the international level, that would make a huge difference. What we are looking for in WHO with my colleagues and partners is the resourcing, the partners, the NGOs on the ground to work with people so that the experience that has just been described does not become the reality with this situation.
Doreen, Dr. Mayeti, thank you so much. And again, feel free to talk to each other on the show. This is Dear World Live. We are live. For as long as we have Doreen, we will come to her. But for now, I'd like to go back to Khadija. And in fact, I would like all of my guests on the screen at the same time, if I might have them. There you all are. Wonderful. So, Khadija, this is the part of the discussion, folks, where we can talk to each other. Feel free to talk to each other without my interference. We've got wonderful comments and questions coming in from our viewers at Wish and online, wherever they're streaming. And it's now time to have a bigger discussion. Khadija, why don't you kick us off? Do you have a question for our guests? For whom is it, and what is your question?
Sure. So my question is essentially, you know, we know with the coronavirus pandemic that it has highlighted key issues, especially relating to institutional racism that exists in many systems across the world. And my question is, do you think the coronavirus pandemic has essentially worsened the racial inequality that exists, or it's simply just exposed what is already there?
I mean, I could answer that to begin with, if you like, Nilofer. I mean, Khadija, thanks for the question. I think the answers are very simple. It has exposed it to a wider audience than previously, public than previously, but also it's made it worse. As we were saying previously, the health system is stressed. Every health system is stressed. They're under pressure, and at times like that, inequalities, unfairness becomes worse. And unfortunately, it's made much worse in this pandemic because much of the workforce, the people exposed, trying to save lives, trying to get you to work, are from ethnic minorities and minority communities. And it's the frontline people who have the greatest exposure, and the people in the poorest communities, who are often minority communities, who are then unfortunately suffering the worst outcomes. So yes, to both your questions, it's exposed it more and it's made it worse.
Dr. Moyeti, please.
Sure. If I may come in as well, I agree very much with what was just said. And then also, because the COVID-19 pandemic has had a huge economic impact, huge and immediate, both at the level of individuals, the livelihoods, households, and countries' economies. So I think not only has it highlighted inequities, not only has it worsened them, but it's going to worsen them going into the future. So for those people, for example, in the inequitable systems that we have around the world who do not have medical insurance, and certainly for people who've lost their jobs and therefore lose their medical insurance, or as is the case in African countries, most people don't yet have medical insurance, so people have to pay out of pocket. And if you lose your livelihood, then you cannot pay for healthcare. So, and then other factors that influence health going into the future, nutrition, access to good food. It is going to have an impact not only now, but also going into the medium term, into the future. African countries are going to be struggling with their financing for health because their economies are so severely affected by this, by the pandemic, and therefore this is going to have wholesale impact on health, not only now, but going into the future.
Doreen, do you want to
say on things are done?
Khadija, do you have another question? Doreen, does anyone want to talk? You feel free to talk to each other, guys.
I mean, sorry. After you, Doreen.
Okay. Personally, I just want to highlight something that has come up that I've actually noticed during this pandemic. The stigma that, and I want to tie it with the HIV factor. HIV currently has the issue of stigma and discrimination among people living with HIV. And we have seen it come out with the COVID-19 pandemic. We saw that at some point you were even afraid to sneeze or cough in public because you don't want to be termed that you have COVID-19. And people were, when COVID first started in Kenya, when we first recorded our first case, people were being taken to quarantine, and it was almost looked like a criminal kind of thing. And the more days went by, the more people were like forced into some sort of quarantine, and you now feel like you are not part of society, you're not an acceptable person because you might have COVID. So I'm just wondering, is there something that can be done by governments, by healthcare institutions, so that we don't end up with another pandemic that has stigma come with it? Because we all know the effects of stigma. They are just so adverse.
I'm just going to summarize for our viewing audience. All of you watching online, you are so welcome. This is Dear World Live, a very important conversation about healthcare inequality, both in countries and around the world. I am joined by a marvelous ensemble of guests, and we're having this discussion now. Khadija, I want to come to you, but I want you to add to what Doreen was saying, and perhaps you've got a question for all of us, if we can get everyone on at the same time. Doreen is making a very valid point, folks. This idea of stigma, of fake news, of talking about the vaccine in a term where people might not take it just because they don't know what's in it. That's a really important part of being a physician and providing healthcare and correct information. I want us to start thinking about that. But Khadija, do you have any more questions that you want to ask?
Yeah, definitely. I think, especially with what Doreen has mentioned in terms of the stigma, that was a huge particular issue, especially at the beginning around when coronavirus was becoming such a big issue. When it comes to spreading fake news, we all know about the WhatsApp broadcast messages to our parents, our grandparents, spreading a huge amount of fear amongst them. And it just goes to show that this is going to be a long road to actual gaining some sort of normalcy, let's say. And things need to happen at a governmental level, but also in our healthcare systems. So my next question would be, what are some of the solutions? How do we try and fix some of these disparities that exist within healthcare caused by the racial inequalities?
So, I mean, can I come in now, Neela? I mean, I think I was going to follow on to say I agree with what Dr. Moeti said about the economic impact. The issue of stigma is very important, but it comes back to government, which is what you've highlighted here, Khadija. I think there are two tracks here. One is a longer term track, which is addressing the structural racism, and if we're allowed to use that term, I think we should. That has got us into the position that we are now in many societies across the world. So, but that's a long-term fix of society, of institutions, of politics, and that's an overhaul that needs to begin, and that requires very strong leadership. The second track is the immediate challenge of what to do about COVID, and the frustration here is that let's go back to racism and the disparity in outcomes. The evidence emerged very early. It's clear we know that minority communities are adversely affected. Governments have that data, health services have that data, but what action are they really taking to address that? They are not taking the required action to address those inequalities immediately. In care. It's very, very frustrating, and I can say that's happening in the UK. I'm sure it's happening, we know it's happening in the US as well, and in other places. So if we're looking to address the challenges that we have now, it's the governments, the leaders of the health services that need to immediately prioritize the welfare of minorities because they are most at risk from this pandemic, and they are not responding to the data and the evidence that we have that they are most at risk. So it's a failure of leadership, and that needs to be urgently tackled.
I would like to thank Khadija for doing my job for me and asking to think about the solutions, both on a macro and micro level. She obviously has access to my scripts that I didn't know about. Doreen, I want to come to you, and then Dr. Moeti. What can we do on an individual level? And to what Dr. Abasi said, on a macro, on a wider level, I can't change governments, but maybe there's something I can do personally that might make a difference. Doreen, let me come to you first, and then have a think, Dr. Moeti, as to what you might say.
At the end of the day, it boils down to you as a person, as an individual. How responsible are you? How well are you taking care of yourself? Because now we have a way where our healthcare systems, even right now, they're already strained. And we have seen even most of the most powerful healthcare systems in the world are very strained right now. So when it comes to a country like Kenya, where I'm speaking from, and we already strained when it comes to the medical professionals and practitioners, and we are even seeing that people in the front line, they're dying. So me as an individual, before I task the government that what are you doing for our doctors, or what are you doing here and there, what am I doing? Am I following the protocols that have been put in place? Am I following the safety measures that have been put in place? Am I taking care of myself and even my loved ones? Because we might blame the governments all we want, but at the end of the day, we also have a responsibility to play, that I will go out and not ensure that I maintain social distance, and ensure that I keep myself safe. I go out with a mask, because right now we have a pandemic on our hands that the whole world is struggling with. So you don't want to be part of the statistics that actually will be counted that we lost so and so to coronavirus. So you need to also have that individual responsibility, that I am going to keep myself safe and also the people around me safe.
Dr. Moeti.
Yes, I of course, as somebody who works on policy, on national strategies, I recognize that sometimes you can be waving evidence under the nose of politicians, and if some political imperative necessitates it, they will ignore it. So, evidence and common sense don't always translate into appropriate policies and action. But I do believe that some of the things that we need to do as a World Health Organization, which we are doing all the time, I have to say, is to advise governments to base their actions on evidence and on determinants. So we need coalitions of groups that are going to look at influencing the way governments are behaving. I do believe that there is something that citizens can do. The difference between HIV and the COVID-19, I think, is the speed at which it has unfolded. Like I said, I gave that example of in order to get a US president to shift the policy and doing something different, we had citizens, people who were affected, others who were supporting this work, WHO and other organizations working together to persuade people this is actually what's going on. Do something based on these facts. So my response is to say we need different people. And I do believe it's possible. The BMJ, the British Medical Journal, which is an influential international journal, I'm sure you're writing about that, the fact that what we see is actions that don't actually follow the data, and therefore the impact is going to be limited, or it's going to be inequitable as usual. I think it requires all of this. It requires those who can have influence. It requires citizens themselves. It requires international organizations, perhaps to be less diplomatic than we normally are in addressing some of these factors. It really requires this collective action. And at the end of the day, some of what we do is to show the political leaders what a huge economic impact for everybody having these inequities and vulnerabilities in certain groups are going to have. If you look at all the arguments that are going on in Western countries now about lockdowns, it's not that everybody is affected equally, but if proper attention is not paid, then the lockdowns are going to affect economies generally, apart from one industry, which is to do with keeping us connected as we speak.
Khadija, I hope that was a succinct and complete answer. We have Doreen talking about personal responsibility, Dr. Abbasi saying we need to oust these leaders that aren't doing quite enough of what the public want, and Doreen, Dr. Moyetti being as exactly as I expect, saying that it is all our collective responsibility and calling out Ronald Reagan as she should. Thank you to all of you guys. Khadija, I'm gonna pause you for a moment because I've got a question for our three guests. So if we can just have our three guests for this next section. We've been reaching out and we have some wonderful questions from the Qatar Medical Students Associations who have sent us multiple questions. I can't get through all of them right now, so I apologize, but we thank you for contributing. I will get to one question that I want my guests to think about. Ali Al-Amji asks, nationalism and tribalism plays a huge role in the Middle East and all over the world. How can we promote healthcare workers to treat all patients equally? And I just want to build on that to say, Khadija mentioned about the African American community in the US and the BAME community here in the UK, getting different levels of treatment. Racism does not stop. Xenophobia does not stop once you put that white coat on. So talk to me a little bit about how we can mitigate that xenophobia or racism. I want to come to you first, Dr. Abbasi.
Yeah, I mean, this is the kind of $60 billion question, or however much you want to attach to it. Racism is something, I mean, how do you remove it from people, from individuals? We've been trying to crack that nut for a very long time. But I think what we have to do, though, is to look at the structural issues. So the society, the environment, the culture, everything that's made up, address the things we can address, be honest about it, show leadership, measure where those inequalities are, where that racism is, because we know racism is a factor on its own in people's outcomes. So we need to do those things. And then in terms of individuals, in terms of healthcare professionals, I think, A, we change the culture, B, I think it's about how you train people and how you mentor them, how you show them with role models, how they're meant to behave with people from different backgrounds. Because ultimately, as a health professional, your duty is to that person, that individual, regardless of race, religion, ethnicity, culture, sex, whatever. Your duty is to help them. And
Your duty is to help
it goes back to training.
Dr. Abbasi, I'm so sorry to interrupt. The time has absolutely gotten away with me, and we have barely moments left. So I want Dr. Moyeti to pick up on what you said. Your duty is to your patient, and that is the most fundamental thing. Dr. Moyeti, with the little time that we have, I'm sorry to force you to answer, but what would you make of that?
Yeah, no, I agree completely with Dr. Abbasi. And both the structural racism and at the personal level, the unconscious biases. First, I think we need to name it. We need to actually say it is here, it's going on. And we need to learn to talk about it in ways that don't trigger defensiveness in people, etc. So it's a strange coincidence that the Black Lives Matter movement coincided with this pandemic, and it's given the opportunity to actually talk more openly about racism than has been happening, in the last few decades. So I think we need to name it, and then we need to do what Dr. Abbasi said. I agree very much with him.
Name it, Doreen. What do you think? In your experience as a HIV positive person, is naming a thing part of destroying that taboo? In a sentence, I'm so sorry to rush you.
Naming is a thing because, sorry, but I always say the H in HIV stands for human. So the minute that doctor wears their white coat, they have to look at that person as a human. It doesn't matter what color, what race, what background they're coming from. Look at them as a human being.
Thank you so much. If we can get Khadija on as well, I would love to thank all of my guests for this exceptional, wonderful discussion that we have. We haven't solved the issue, but we've started to talk about solutions. Dr. Matshidiso Moyeti, Doreen Maracha, Cameron Abbasi, and Khadija Owusu. Thank you so much. Say goodbye, everybody.
Goodbye.
Thank you so much. And for those of you who are tuning in at Wish and our regular Dear World Live viewers, I am so thankful. I'm sorry I couldn't get to more of your questions. Very wonderful comments and questions coming from all over the place. Dr. Govinda obviously liked it. Mohammed was watching from Sudan. We had people from the United States. Some people praising the diversity of our panel, which I'm always thrilled about. And lots of comments and questions. Thank you so much for that. For those of you who want to get more involved, remember you can always go to dohadebates.com to see more from our show. That is it from Dear World Live and from this season of Dear World Live. You can catch up on our website. Thank you to Wish and from the Doha Debates team. That's all from me. Goodbye.